Louis is Professor of Psychiatry at Manchester State University. He's also Director of NCISH, which is the National Confidential Inquiry into Suicide and Safety into Mental Health. But not only that, he also leads the National Suicide Prevention Strategy for England. So he's in a really important place around really directly influencing the policy in this country. So over to you, Louis.
Thank you very much, Jackie. I'm going to share my screen. I hope that's already apparent.
Yeah, that's perfect.
And I'm going to stop my video. This is just to say hello to everybody, but just to ensure that there's no interruption to the signal. So thank you very much to Andy and to Mike and to Tim. What an incredible story, an inspiring story. And it's been fantastic to watch what you've achieved. Brilliant that you could be with us today. So it's a great start, reminding us of the human side of the figures that we're about to talk about. So to our audience, thank you also for being here. Hope you're well. It's a very important day for the confidential inquiry, for our research unit, and for the brilliant research team who have put together the figures that you're going to hear. This is our annual report. It's an opportunity for us to update on national figures on suicide, and in particular, to focus on the safety of mental health care. This is what I'm going to be talking about today. This is the tragic toll of suicide among mental health patients nationally during the years 2009 to 19. That's the focus. That's a 10-year period, a baseline plus 10 subsequent years of the report that we're presenting today. Altogether, 18,268 mental health patients who died by suicide during that period, 27% of all suicides in the general population. So the numbers are tragic. They sometimes have to be, you have to pause and think about what these numbers are. So over 18,000 deaths that we're basing our findings on. They're very much driven by what happens in England because of the population size, as the map is showing. But I should stress that the patterns that we're talking about, the areas of risk and safety, are fairly common across the UK countries. And just to make the point again, these are not dry data. These figures are real lives. They are real people lost to a preventable cause, and real families devastated. We never forget that in the research that we do. How do we get the data? Well, we start by, it's a three-stage process. We start by taking information from official national sources. So in England and Wales, that's the Office for National Statistics. And there are equivalent organizations in the other UK countries, and they record deaths which are officially recorded as suicide or probable suicide. That's open conclusions or undetermined deaths. And so that takes place following the legal process, following the inquest. Then we establish which of those people in the population as a whole were mental health patients with the help of the local NHS. And we do that by defining a patient as someone who had contact with services in the 12 months before they died. We then write to the clinical team who were providing care for that group, and we ask them some detailed questions about the person, about the circumstances in which the death occurred, and about the kind of care that they were receiving. And around 95%, more than 95% of the clinical teams reply to us. They send back our questionnaires. In research, that's a very high response rate, and it reflects the commitment of mental health services generally to improve safety. So if you have been one of those people who've returned our questionnaire, thank you very much. That return is very important to the findings. The more people who reply, the more confidence we can have in the findings that we present. The process, though, takes quite a long time. It's a single slide, but overall it takes up to 2 years to go from when a death occurs to our reports. bear in mind that even the time from up to an inquest takes an average of 6 months, and in many cases it takes 12 months. So there is a time factor built into when we can report our data. And that's the reason why when we present the figures today, we're talking about 2009 up to 2019. 2019 is the last year for which we have complete data. These are not deaths registered in 2019. These are deaths that occurred in 2019. So you'll see a number of graphs that look a little bit like this, covering this period. Important to say that therefore the figures are all pre-pandemic. They're about the safety of mental health care pre-pandemic. Sometimes you'll see some overall combined figures which are adding all the data for this time period together. So these are UK-wide figures. If you look at the line, let me just see if I can summon up a pointer. There we are. So this figure here, these are numbers. So the total number of deaths per year in mental health patients, by that definition, is what the top line, that sort of purple-colored line, is showing it on average about 1,600 deaths a year. So it's worth pausing just on that figure alone. 1,661 deaths among mental health patients per year. And although there's some fluctuation in the line, it's been a little bit lower in recent years, and then in the last 2 years, a little bit higher. So a possible increase in 2018 and 2019, probably reflecting the general population rate, which has also increased during that time. And we believe, although it's not certain, that may have been influenced by a change in the threshold for inquests to come to a suicide conclusion. So a lowering of the so-called standard of proof towards the balance of probabilities instead of beyond reasonable doubt. Now, these are numbers, they're not rates. So the other thing that's not on this slide is the effects of the huge increase in the number of people who seek and receive mental health care. So the numbers have stayed reasonably stable over the last few years, but the number of people who are under mental health care has greatly increased. And if you take account of that, we can do that. We calculate a rate. This is for England now. You get a very different graph. Now, the key line is the middle one because these are rates. So this is the overall males and females combined. And you can see in recent years, there's been a substantial fall in the rate of patient suicide in England. And there's always a but in suicide statistics, that fall appears to have stalled in the last few years. So it may be an improvement in safety, but it's no longer occurring. And secondly, you have to bear in mind that a fall is what you'd expect if you expand the patient population. So the more people who are under mental health care, the more you're going to bring into the service people who are at lesser degrees of risk. That's an inevitability. And so you would expect the rate to fall to some extent. Even so, this probably represents an improvement in safety during the report period. What do we know about the people who died? Well, this is not a risk factor study. We already know many of the risk factors for suicide. This is asking how often these risk factors occur in patients who die. And in a way, it's asking the prevention question. Whose deaths would we have to prevent to bring down the rate of patient suicide in a substantial way? Who should be the target of our prevention activities? And so here are some of the characteristics of patients who die. What this slide is telling us is that we should build prevention around social adversity. You see figures there for isolation. And remember the total figure, you see a percentage figure there of these very large totals. We can see that there is clinical complexity. So we build prevention around clinical complexity, self-harm, alcohol and drug misuse. We have to be aware of the number of patients who die who are from an ethnic minority and shape our services for a diverse society. And we have to be aware of the personalized nature of risk. We found that 9% of patients who died near or on an anniversary or some other significant date, some of personal significance. Now, 9% may not sound very much, but on such a large total number, it's about 2,000 people during the course of our data collection report. And it reminds us that risk is often personalized. It's often individual. It's often particular to the person. We should build our prevention around acute care. So this is a slide showing the settings, the clinical circumstances in which many of the deaths occur. So these three columns here are the acute care system: inpatient care, recent discharge, crisis teams. And about a third of patient deaths happen just in that part of the care pathway. And in the report, that of course amounts to about 5,000 deaths over the report period. About a quarter of the patient deaths follow evidence that the person was just beginning to lose contact with the service. Missing your last appointment is our marker for that. On the other hand, almost half of patients die within a week of seeing a mental health professional. So an opportunity to build greater safety into the system. But very often the risk is judged at that final meeting to be low. So risk recognition, a particular obstacle. What's happened in those settings? Well, here's what's happened during the years in question to inpatient suicide. And you can see that overall the numbers have come down, and during the whole period, the average number of deaths is around 100, just under 100. You could say, is that because of fewer beds? It's not, because this finding is the same if we look at whether we look at numbers or rates. And it probably represents a genuine improvement in inpatient safety, a tribute to our staff. But I did say there was always a but. Again, that sense that the improvement has recently stalled, so no change in the last few years. And a reminder, this line is people who die on the ward by, and I'm sorry about the grim nature of this, by hanging or strangulation, a very important cause of death among inpatients. And those deaths may be reduced, but they're still occurring. What do we know about the inpatients who die? Well, a number of details on the slide and in the report, but I want to highlight just one for the purpose of today. Inpatient suicide is not the same as ward suicide. About half of the patients who die are on agreed leave from the ward towards the end of an admission, about to take that step into the community. Only about a third die on the ward itself, suggesting physical safety and vigilance. And the rest, about 15%, are people who have left the ward without permission, the so-called absconding problem. And for that group, there's a strong link to people who've recently arrived in hospital. So the prevention implications varied according to different groups. No single cause, no single route to prevention. And then there are the people who've recently left hospital. These figures too are falling, but look at the huge number over the period. This is actually the time of highest risk for mental health patients, just after leaving hospital. And it's not a uniform risk. This is the risk broken down week by week. The risk is highest in the first 2 weeks after leaving hospital. And in fact, it's more than that. It's highest on day 3, the third day after leaving hospital. And our services have to be ready for that transition. They have to be ready to provide early follow-up on departure from hospital. People returning to the stresses that may have brought them in the first place. Now, our reports have these overall figures about clinical settings, about characteristics, but they also have a number of themes, subgroups within the patient population that this year we are highlighting. And there are 4: under 18s, people who are facing economic difficulties, very important at the moment, people who have physical ill health as well as mental ill health, and people who have experienced domestic violence. So the results here are now on these different groups. So first of all, young people, by which we mean people under the age of 18. That's chosen because it reflects contact with CAMHS services. So first of all, a point about the general population. So not patients on this particular graph, this blue graph. Here are the number of under 18s who die by suicide each year in England. And overall, the figures are slowly rising during the time of the report period. This is the UK, I should say. And then we get to 2017, and we see this very unusual and abrupt rise in the number of deaths in young people, children and adolescents, which remains unexplained, although, again, it's the first group who might have been affected by the change in the inquest process, which lowered the standard of proof required for a suicide conclusion for coroners. So it may be a recognition of the true numbers. And this rise in particular has affected girls rather than boys. Affected both, but girls proportionately more. And then what about the patients? Well, patients, a similar sort of pattern, numbers are much smaller. In fact, 19% of general population young people suicides are people who are in contact with mental health services, with CAMS services. So that's less than the 27% I mentioned earlier for the whole all age population, suggesting a particular problem of access for people in this age group. But again, what looks like a rise over the time period, there's that peak a little bit more marked in the patient population. A little less marked, sorry, in the patient population. What do we know about the patient group now? Well, an important point is that when you look at a subgroup of the patient population, you don't simply find the same risk factors, risk indicators, but in a different setting. You often find particular risks which are specific to that group. It's part of the individual nature of risk, and it requires a different prevention response. And many of the factors for this group reflect the lives of young people. What do we mean? Well, there's a different pattern of suicide methods. Now, I'm not going to go into this in detail, but it's a very sensitive, potentially distressing topic, but enough to say that it's an important point that young people tend to die by methods which are more likely to have a fatal outcome. And that's a very important potential driver of a rise. We talk about risk factors and social circumstances, clinical care, but the method by which young people choose to harm themselves and how they know about that method is an important route to prevention too. There's a higher proportion of girls. So in the population of patients as a whole, females make up about a third, but in this under 18 group, it's around half. Certain risk factors are particularly common, more than in older groups, so self-harm, for example, but also certain diagnoses, autism, eating disorders, a more important focus for prevention in this age group. Then suicide-related online activity, more common in young people. 25% had that kind of experience compared to about 7% in the patient group as a whole. And it isn't just social media that we're talking about here, it is also searching for suicide methods online. There's a lot of undesirable information online that we need to protect young people from in a more effective way. So, young people, what about economic adversity? Well, we haven't been asking detailed questions about it throughout the time period, so it's a slightly shorter graph starting in 2013. What do I mean by economic adversity? Well, it's a range of pressures, financial difficulties, debt, problems at work, and housing, instability, and homelessness. But if you add those things together, it's quite a large proportion of patient suicides, a large number of people experiencing these stresses before they die. And it's a reminder that the job of mental health services is to link to the agencies that deal with economic support. And that often means the voluntary sector. And as we look ahead, and the poor economic, the bad economic news at the moment, this will be a particularly important collaboration. What do we know about those people? Well, here we're comparing those who die while facing economic adversity with patients as a whole. And we're asking, is there any difference? Is there anything that makes our approach to prevention more individual? Are there groups of factors which tell the story of people's lives, these factors coming together to add up to risk in individuals? There's different combinations of these features. And the answer is yes, we find that this group, facing economic adversity, often men in middle age, often with a problem of alcohol or drugs. They're people who are more than patients in general, are losing contact with services. They're disengaging through missing appointments, not following their treatment plan. And their disengagement is partly clinical, but it is also social. There's a general sense in which they are losing their ties with society, economically, socially, and clinically. And it's our job in services to provide the kind of outreach support that covers that set of isolating difficulties. What about people who have coexisting or comorbid physical illness? Well, what do I mean by that? Many of it's a very large number. It's about a quarter of patient suicides have some kind of significant physical illness, and the numbers again are very high. And what we usually mean by that is that they have some kind of cardiovascular disorder, or neurological, or neuromuscular, or respiratory. Those are the main conditions that people were suffering from. And if we look at the period over the report, at the time of the report, a slightly unexplained drop in those numbers, but in the last several years, what looks like a steady rise, either in the co-occurrence of physical ill health or in the recognition of it by mental health services from around about 2014. And of course, it's a strong argument for joint care of a physical and a psychological kind, collaborative working across those parts of the NHS. What do we know about those people? Well, again, compared to patients in general, we know there are some difficulties, some particular individual difficulties that mark out this group and should help shape prevention. They're a little bit more likely to be women. Of course, they're more likely to be in their older age groups. They're living alone, single, divorced, and widowed. So a group of circumstances which needs to be at the forefront of social support and prevention. The common risk factors for suicide, like drugs and alcohol misuse, which you find in most populations, are less prominent in this group. And so that's less important as a prevention approach. These are the factors which will lead us to prevention for this subgroup. And self-poisoning as a method of suicide is more common. It's not the most common method, but it's more common than in other patients. And when self-poisoning is the method, opiate drugs are more likely to be used. And when opiate drugs are used, prescription is the more likely source. So people are taking the drugs prescribed, and safer prescribing is an important part of prevention. But so for mental health services is checking people's access to pain-killing drugs, which could play a part in suicide risk. And then we have domestic violence. Now we started asking about domestic violence relatively recently. So a shorter graph, and you can see what this rise here means is that people were not used to answering that question initially, and maybe didn't initially get our new questionnaire. So so gradually you can see us becoming more aware of the true figures in the later part of the graph, where we are seeing around 150 deaths per year in people who have experienced domestic violence. That's quite a large proportion of patient suicides overall. And of course, it's more common in women, in whom it's around 18% of patient suicides, who are people are also experiencing domestic violence. So again, how do those women compare to other female patients who die? Well, they're slightly younger, they're more often single or separated. It's fair to say they're facing difficulties of a more general kind. They're facing social difficulties, living alone, economically stressed. Perhaps they also are facing other clinical difficulties, alcohol and drug misuse, and then the diagnosis of personality disorder, not our favorite diagnosis. We've published reports on this and its pejorative nature, but it is used, and so we record it. Personality disorder is a diagnosis often applied to people who've had experience of abuse in childhood that's been harmful to them emotionally when they become adults. And it may be that what we're seeing here is a continuity of people on the receiving end of unacceptable abuse. So they're facing stresses in their lives, and it's a reminder that domestic violence occurs alongside other risks. And part of our assessment of risk, particularly in women, is to assess the risk that they may also be victims of domestic violence. So those are our themes, but there's one other one that I must mention because COVID has dominated our work over the last 2 years. If you remember, right at the beginning of the pandemic, there was a huge concern that the pandemic would cause an enormous rise in suicide. But we had no way of knowing because figures from ONS and from other official sources take some time to come through the system. The delay in inquests is many months, and of course it was greater during the early pandemic. Now, just to be clear, there's no question that the pandemic has adversely affected our mental health and put some people at greater risk. The question here was, has it also translated into a large rise in suicide rates? And now we're talking about general population and not patients. So we were able, because we work with a number of local areas, we were able to draw from the data that they collected through real-time surveillance. And real-time surveillance is a way of recording deaths as they occur, not waiting for inquest. So it gives you a more immediate picture. And so we put together the real-time figures from a number of parts of the country where we knew that they had reliable data, and they're marked on the map. About 10 parts of the 10 NHS regions, STPs, about a quarter of the country. And initially we published figures for the first few months of the pandemic, but now we have figures from before the pandemic began right up to October 2021, so just towards the end of last year. These are the most up-to-date figures that you will see, and they're not yet published. And here's what we found. Here's the pre-pandemic suicide rate in those areas. Here's lockdown, no change. Here's the post-lockdown opening up. No change, in fact, a slight fall probably there, into second lockdown and beyond right through the course of this year. Some volatility in the figures, but no rise in the number or the rate of suicides suspected through real-time surveillance. And of course, ONS have now published some figures during the course of last year, covering the first part of this graph, confirming no rise, although they in fact found a small fall. What does this mean? It doesn't mean that we've got away without harm to our mental health. It doesn't mean that. It does mean there hasn't been a substantial rise in suicide, maybe no rise at all. It's not the final word, because in mental health terms, we're probably still in mid-pandemic. It doesn't tell us about individual populations like young people or ethnic minorities or people who are facing economic difficulties. These are overall figures for the population. And it doesn't tell us where we're heading in the future with the economic pressures that people are now finding and new risks like long COVID. So to summarize, what are the clinical messages from our report today? Well, there are several. I hope they were apparent as we were going through the findings, but just to summarize some of the main ones. In clinical practice, we should be aware of the particular risks that people face around certain dates. That message of risk being individual and personal. We should keep up our focus on the acute care system, ward safety, and early follow-up on discharge. We should focus on young people in whom rates have been rising, with a particular concern about access to mental health services. We need to work in mental health services with people who agencies that support those who are economically stressed, and with physical health services, with a particular eye on the availability of opioid drugs to people who might be at risk. And we need to consider domestic violence as a routine part of suicide risk assessment, particularly in women. And all of these messages add to our wider messages over the years, known to our previous reports as the 10 ways to improve safety, the best evidenced approaches to suicide prevention. Very important that every service in the country is adopting these 10 ways. I'm not going to go through them all, but here are some of the ones I've mentioned today. Safer wards, early follow-up, the importance of alcohol and drug misuse, the importance of outreach teams and crisis services. Here's personalized risk management, not checklists. And here is the learning culture a learning organization, learning when tragedies occur, and involving the families of people who die in learning those lessons. That's what we've tried to do in our work, and I hope people have found that useful today. Just a reminder of the team, our excellent team who produce all the data that you've been looking at. Thanks very much for listening.